All right, let's bypass the pleasantries and jump right into the high-yield material. If you're aiming to master the radiographic and biochemical signatures required for a 270-plus score, you are absolutely in the right place. In this explainer, we are locking down the exact mechanisms, discrete management steps, and clinical traps for primary bone malignancies and adnexal masses. Let's get to it. We'll kick things off with a major presentation, osteosarcoma. This is a highly aggressive proliferation of malignant osteoblasts. Its defining geographic signature? It strictly localizes to the metaphyseal regions of long bones. We're talking specifically about the distal femur, proximal tibia, or proximal humerus. Clinically, you're looking for a patient presenting with a tender soft tissue mass and progressive bone pain that notably worsens at night. The radiographic reality of this disease is striking. You can literally see the destructive, bone-forming lesion displaying a classic, spiculated sunburst pattern. You'll also frequently spot a Codman triangle, which is that distinct, sharp lifting of the periosteum at the edge of the lesion. This is a highly aggressive tumor with a poor prognosis, typically mandating immediate surgical resection and chemotherapy. Now, the absolute trap here is missing the genetic foundation. You have got to hardwire this connection. Metaphyseal destruction heavily links to specific genetic risks. Familial cases are deeply tied to the RB1 gene mutation, which means a very strong association with bilateral retinoblastoma. It's also tied to p53 tumor suppressor mutations. And don't forget the bimodal age distribution. While it's common in teens, in older adults, osteosarcoma often arises as a sarcomatous transformation from Paget disease of the bone. Contrast this directly with our next major player, Ewing sarcoma. Instead of the metaphysis, this malignancy strictly targets the diaphysis, or the midshaft, of long bones. It's a neuroectoderm sarcoma driven specifically by the T11-22 chromosomal translocation. Because Ewing expands so rapidly, it creates a very distinct multi-layered periosteal reaction. It has this classic onion skin appearance, which can eventually be followed by a mottled, moth-eaten look extending right into the soft tissue. But here's the massive clinical trap. Ewing sarcoma frequently presents with systemic symptoms like fever, leukocytosis, and an elevated ESR. It aggressively mimics a bone infection. You absolutely cannot confuse those aggressive malignancies with osteoid osteoma. This one is a benign bone-forming tumor. On imaging, it presents as a small radiolucent nidus surrounded by a dense sclerotic border. The defining clinical signature is severe, localized bone pain occurring strictly at night. But the giveaway? That pain is completely and rapidly relieved by NSAIDs. Why? Because the tumor itself produces incredibly high levels of internal prostaglandins. Let's pause for a clinical variance box because this is where the diagnostic challenge really peaks. We need to separate Ewing sarcoma from osteomyelitis in pediatric patients. Both of these present almost identically on the surface: localized diaphyseal bone pain, fever, swelling, and leukocytosis. So how do we tell them apart? The clinical divergence is all in the diagnostics. Ewing sarcoma features that destructive onion skin reaction, and on histology, you'll see small, round blue cells, requiring an oncologic bone biopsy. Osteomyelitis, on the other hand, is often driven by Staph aureus or salmonella in sickle cell patients and features elevated inflammatory markers that mandate blood cultures. For osteomyelitis, an MRI is your imaging test of choice, and the treatment is surgical debridement followed by prolonged IV antibiotics, definitely not chemotherapy. Okay, let's test this framework with an integrated assessment. Picture a 14-year-old male presenting with left knee pain and a mass at the distal femur. Imaging shows a distinct sunburst periosteal reaction. You are asked to explicitly identify the underlying genetic risk factor. Evaluate these 5 distinct answer choices carefully. We've got the T11-22 translocation, the T15-17 translocation, an autosomal dominant COL1A1 mutation, an RB1 mutation, or a WAS gene mutation. Your goal is to isolate the precise systemic variable causing this specific radiographic presentation. If you locked in option 4, the RB1 mutation, you nailed it. Let's break down exactly why. The patient has a metaphyseal mass with a sunburst pattern that is classic osteosarcoma, heavily linked to the RB1 mutation and bilateral retinoblastoma. Let's run through the distractors to be exhaustive. Option 1, T11-22, defines the diaphyseal Ewing sarcoma. Option 2, the T15-17 translocation drives acute promyelocytic leukemia presenting with systemic hemorrhage. Option 3, a CLI1A1 mutation causes osteogenesis imperfecta, marked by blue sclera and fragile bones. And option 5, the WAS gene, causes Wiskott-Aldrich syndrome, marked by eczema and immunodeficiency. Option 4 is the only fit. Moving right along to Module 2, we're tackling adnexal masses, specifically focusing on germ cell spikes and tumor marker specificity. Let's break down these distinct markers for young female ovarian masses. Yolk sac tumors aggressively secrete alpha-fetoprotein, or AFP, and present grossly as a yellow, friable mass. Histologically, you've got to look for pathognomonic Schiller-Duvall bodies. Disc germinomas are essentially the female equivalent of seminomas. They explicitly elevate LDH and HCG and display sheets of uniform fried egg cells. Choriocarcinoma is a trophoblastic malignancy that massively elevates beta-HCG and spreads hematogeneously. Finally, teratomas contain multiple germ layers and can elevate AFP, beta-HCG, or even both. Shifting gears to stromal secretions, let's talk about granulosa cell tumors. These are malignant sex-cord stromal tumors that autonomously secrete massive amounts of estrogen and sometimes progesterone. They're also known for producing inhibin. If you biopsy them, histologically, you will find classic rosette-like structures called Cal-Exner bodies. Now, this unopposed estrogen causes some extreme systemic effects. In young children, it strictly drives precocious puberty, presenting with breast hypertrophy and pubic hair growth way too early. In adults, that continuous estrogen stimulation directly drives concurrent endometrial hyperplasia or even endometrial adenocarcinoma. This typically presents clinically as severe abnormal uterine bleeding or postmenopausal bleeding. Time for another clinical variance box. This time, we're isolating two unilateral solid ovarian masses in young women, yolk sac versus granulosa cell tumors. Both can present as a palpable pelvic mass, but their systemic profiles are totally different. The divergence between these two is absolute. Yolk sac tumors are highly aggressive germ cell tumors that massively elevate AFP, but crucially, they do not alter the patient's menstrual cycle or feminize the patient. Granulosa cell tumors, however, are sex-cord stromal tumors that hypersecrete estrogen. This fundamentally alters the systemic hormonal balance, causing precocious puberty or abnormal bleeding, complete with those Cal-Exner bodies on histology. Let's apply this logic to our final integrated assessment. You've got a 22-year-old female presenting with a 10-centimeter solid right ovarian mass. She reports absent menses for 4 months, a deepening of her voice, and on physical exam, you note clitoromegaly. What is the diagnosis? Evaluate these 5 strictly defined adnexal mimics carefully. Are we looking at a granulosa cell tumor, a yolk sac tumor, a disc germinoma, a Sertoli-Leydig cell tumor, or a choriocarcinoma? Keep the specific hormonal effects we just described front and center. And the correct answer is option 4, the Sertoli-Leydig cell tumor. The clinical presentation of a deepening voice, clitoromegaly, and amenorrhea indicates overt masculinization and defeminization. This matrix forces the identification of a Sertoli-Leydig cell tumor via its highly specific androgen-secreting profile. Let's exhaustively rule out the rest. Option 1, the granulosa cell tumor drives estrogenic feminization and bleeding. Option 2, the yolk sac tumor secretes AFP with no virilization. Option 3, dysgerminoma secretes LDH and HCG, again, no virilization. And option 5, choriocarcinoma is a trophoblastic tissue issue secreting beta-HCG. Option 4 is the only one that perfectly fits the clinical picture. As we wrap up this explainer, I want to leave you with a crucial question. When the next vague clinical mass presents on an exam, or more importantly, in your clinic, what singular metabolic variable will you isolate to guarantee the diagnosis? Medicine is all about finding the signal in the noise. Pinpoint the marker, identify the cell of origin, and you control the clinical outcome. Keep studying hard, and I'll catch you in the next explainer.